Anemia. Definition: reduction in one of the following parameters: RBCs count, hemoglobin concentration, or hematocrit value. RBCs count normally from 4.5 to 6 million per cmm in males. Hemoglobin concentration normally from 13.5 to 17.5 in males. Hematocrit value or packed cell volume normally it's 45%. Females are usually 1 to 2 gram hemoglobin and about 1 million RBCs per cmm less than males, due to the effect of androgen in males plus the effect of menstruation. Pathophysiology: hyperdynamic circulation, short circulation time, and high cardiac output. Increased erythropoietin by the kidney to increase RBCs. Increased oxygen delivery. Shift of oxygen dissociation curve to the right due to excess production of 2,3-DPG, which is 2,3-diphosphoglycerate, which can make the binding between oxygen and hemoglobin very weak. Redistribution of blood. Blood is shifted to the vital organs, such as brain. Clinical picture. Symptoms: it depends on the rate of reduction rather than the absolute value of hemoglobin. General, CVS, CNS, and gentle. General: fatigue. CVS: manifestations of low cardiac output in spite of high cardiac output by the hyperdynamic circulation. CNS: loss of concentration, headache, and dizziness. Gentle: impotence, menstrual irregularities. Signs: pallor, hyperdynamic circulation manifesting as tachycardia, increased S1, gallop, and hemic murmur. Lower limb edema due to hyperdynamic circulation, hypoxia, and heart failure. Papilledema and retinal hemorrhage due to increased permeability. Investigations: anemia is not a diagnosis, it's an abnormal clinical finding requiring an explanation for its cause. CBC: RBCs and hemoglobin are reduced in all types. YBCs and platelets are reduced with megaloplastic and aplastic anemia. MCV, MCH, MCHC, normal in hemolytic and aplastic anemia, decreased in iron deficiency anemia, and increased in megaloplastic anemia except for MCHC, which is normal. Color index normally from 0.9 to 1.1, except in iron deficiency anemia it's less than 1, while in megaloplastic anemia it's more than 1. Bone marrow examination: erythroid hyperplasia in iron deficiency and aplasia in aplastic anemia. Hepatic and renal investigations, KEFTs and LEFTs. Treatment: blood transfusion, packed RBCs, treatment of the cause, and treatment for complications. Classifications of anemia. According to pathophysiology, we have decreased production, increased destruction, and increased RBCs loss. Decreased production, decreased hemoglobin synthesis, as in iron deficiency anemia, thalassemia, anemia of chronic diseases. Decreased DNA synthesis, megaloplastic anemia. Decreased stem cells, as in aplastic anemia. Increased destruction, hemolytic anemia. Increased RBCs loss, acute post-hemorrhagic anemia. Classification of anemias by cell size: microcytic hypochromic, normocytic normochromic, and macrocytic. Macrocytic: vitamin B12 deficiency, folic acid deficiency, myelodysplasia, myxedema, alcohol, chronic liver diseases. Normocytic normochromic: hemolytic aplastic anemia, anemia of chronic diseases, and acute post-hemorrhagic anemia. Microcytic hypochromic anemia: whether iron deficiency anemia, thalassemia, anemia of chronic diseases, and sideroblastic anemia. Iron deficiency anemia. Introduction: dietary sources of iron are red meat, liver, eggs, green vegetables, and normal diet provides about 15 mg of iron per day. Iron is recycled and then conserved by the body. Only a small fraction of body's iron is gained or lost each day, 1 to 2 mg. Most of iron in the body lies within the RBC, so chronic bleeding is a potent cause of iron deficiency. Absorption: ferric form is converted to ferrous form by HCl in the stomach. Iron is mainly absorbed in the duodenum and proximal jejunum. It's transported in plasma bound to transferrin. Storage iron occurs in two forms: ferritin in tissues and hemosiderin in bone marrow. Assessment of iron status. Serum iron on its own is not very useful. It's reduced in patients with inflammatory diseases, and it should be always measured with total iron binding capacity, TIBC. Total iron binding capacity, or transferrin, it indicates the maximum amount of iron needed to saturate plasma or serum transferrin, which is the primary iron transport protein. Transferrin saturation, dividing the TIBC by the serum iron, normally it's from 20 to 50%. It's low in iron deficiency and high in iron overload. Serum ferritin major transport and storage form of iron, which is high in iron overload and low in iron depletion, but it's one of the acute phase proteins such as CRP and ESR, which are raised in inflammatory illnesses. So when they are raised, they indicate that the serum ferritin may not be an accurate reflection of iron stores. Iron stain on particles for bone marrow aspirate. This is a gold standard, but it's invasive. Serum soluble transferrin receptor, high in iron deficiency and low in iron overload. It's still a research tool, but still promising. Etiology: chronic blood loss, the most common cause, such as menorrhagia, piles, anal fissures, ankylostoma infection, esophageal varices, and peptic ulcer. Decreased iron intake, decreased absorption of iron, as in malabsorption syndrome or achlorhydra. HCl is responsible for transformation of ferric to ferrous form to be absorbed, and increased demand of iron, such as pregnancy and puberty. Compensatory mechanism of iron deficiency leads to increased absorption from the intestine, increased synthesis of transferrin, iron-carrying protein, and decreased transferrin saturation from 33% to 10%. Clinical picture: general manifestations of anemia plus pica, perverted appetite, nails, brittle, spooning, chylonychiasis, angular stomatitis, ankylocytis. Clinical picture of the cause: ankylostoma, GIT manifestations, abdominal pain, Plummer-Vinson syndrome, iron deficiency anemia with dysphagia, and you can find angular stomatitis. Investigations: CBC, reduced RBCs and hemoglobin, reduced MCV, MCH, MCHC, color index less than 1, bone marrow examination, erythroid hyperplasia, and it's not essential for the diagnosis of iron deficiency. Iron profile: decreased serum iron, serum ferritin, and transferrin saturation, while increased total iron binding capacity. For the cause: stool analysis for ankylostoma, you can find the ova. Endoscope may be needed to detect the site of chronic blood loss, such as peptic ulcer. We have differential diagnosis for microcytic hypochromic anemia, iron deficiency anemia, anemia of chronic diseases, thalassemia trait alpha or beta, sideroblastic anemia. MCV is reduced in iron deficiency anemia, low normal or normal in anemia of chronic diseases, very low for degree of anemia in thalassemia, and low in inherited type of sideroblastic anemia but raised in the acquired type. Serum iron is reduced in anemia of chronic disease and iron deficiency anemia, while it's normal in thalassemia and raised in sideroblastic anemia. Serum TIBC is raised in iron deficiency anemia, reduced in anemia of chronic disease, normal in sideroblastic anemia and thalassemia trait. Serum ferritin reduced in iron deficiency anemia, normal or raised in anemia of chronic disease, normal in thalassemia, raised in sideroblastic anemia. Iron in bone marrow absent in iron deficiency anemia while it's present in the rest of the cases. Iron in erythroblasts, it's absent in iron deficiency anemia, absent or reduced in anemia of chronic disease, and present in thalassemia, while in sideroblastic anemia it's manifested by ring forms. We're going to talk about it later. Treatment of the cause: ankylostoma, peptic ulcer, menstruation, etc. Iron therapy. The response to iron therapy can be monitored using reticulocytic count and hemoglobin level. Hemoglobin should rise by 1 gram percentage per week. Oral, each tablet given per 8 hours. Ferrous sulfate, 200 mg. Ferrous gluconate, 300 mg. Vitamin C can be given to improve the absorption, but the side effects are nausea, vomiting, abdominal pain, and dark stool. Parenteral iron, indicated in oral iron intolerance, malabsorption syndrome, GI disorders such as peptic ulcer. Rapid iron loss. Preparations: iron dextran, 100 mg per day intramuscular or intravenous. Iron sorbitol, 500 mg per day intramuscular. Side effects are anaphylaxis, abscess, fever, skin pigmentation. Sideroblastic anemia, refractory anemia due to ineffective hemoglobin synthesis, failure of incorporation of iron into hemoglobin molecule, and this leads to accumulation of iron in the mitochondria, forming ring of iron granules around the nucleus, leading to ring sideroblasts. Causes are inherited and acquired. Inherited, it's X-linked disease, while acquired, Primary, secondary. Primary, one of the myelodysplastic disorders. Secondary, due to alcohol, lead poisoning, cancer, and drugs, such as INH. Aplastic anemia, anemia due to bone marrow failure. Etiology, primary and secondary. Primary, idiopathic, probably autoimmune. This is the most common cause. Secondary, replaced bone marrow or depressed bone marrow. Replaced bone marrow, malignancy, myelofibrosis, and myelosclerosis. Malignancy such as leukemia and lymphoma. Depressed bone marrow, irradiation, infection, hepatitis and Epstein-Barr virus. Immune, SLE, iatrogenic, antibiotics such as chloramphenicol, antineoplastic azathioprine, antiepileptic phenytoin, antidiabetic chlorpropamide, antithyroid carbimazole, antirheumatic gold and penicillamine. Clinical picture: anemia, leukopenia, and thrombocytopenia. Leukopenia by recurrent infections, thrombocytopenia by purpura and bleeding. Investigations: CBC. The hallmark of aplastic anemia is pancytopenia, but early in the evolution of aplastic anemia, only one or two cell lines may be reduced. MCV, MCH, MCHC are normal, decreased reticulocytes. Color index normal. 1. Bone marrow examination, hypocellular marrow with increased fat spaces, no abnormal cells. Treatment: supportive treatment plus ABC, and this is a mnemonic that I haven't invented. Supportive treatment: red cell transfusion for anemia, antibiotics for infections, platelet transfusion for bleeding, A. androgen or oxymethylone, bone marrow stimulant, bone marrow transplant in severe cases such as children, and C. cause treatment. Differential diagnosis of pancytopenia: aplastic anemia, megaloplastic anemia, hypersplenism, myelofibrosis, myelosclerosis, subleukemic leukemia, PNH, or SLE Felties syndrome. PNH, I think it's nocturnal hematuria. Megaloplastic anemia definition is hematological disorder characterized by pancytopenia with 4 criteria. The 4 criteria are evidence of macrocytosis, good response to vitamin B12 and folic acid, neurological and GIT manifestations, and finally megaloplastic hyperplasia of the bone marrow. Pathophysiology: arrest of division, as vitamin B12 and folic acid are essential for DNA synthesis, and this will result in big cells. Ineffective erythropoiesis: most of megaloblasts undergo intramedullary hemolysis. Evidence of macrocytes: some megaloblasts can escape the bone marrow and appear in the blood as macrocytes. Rapid hemolysis: macrocytes are rapidly sequestered by spleen. Etiology: vitamin B12 deficiency and folic acid deficiency. Vitamin B12 deficiency: diminished intake of vitamin B12, which is present in animal products. Decreased absorption, pernicious anemia is the most common cause. Gastrectomy, chronic gastritis, malabsorption syndrome, ileal resection. Chronic liver diseases: body stores are sufficient for 3 years, and transcobalamin 2 deficiency, which is rare. Pernicious anemia means autoantibodies fighting parietal cells, leading to reduction in production of intrinsic factor, which is necessary for absorption of vitamin B12. It's rare before 35 years old, and it may be associated with premature gray hair and other autoimmune diseases such as myxedema and vitiligo. Folic acid deficiency, vitiligo, not vitiligo. Folic acid deficiency: decreased intake, lack of vegetables, fruits, and alcoholism. Decreased absorption, malabsorption syndrome, increased requirement, pregnancy and malignancy. Drugs: methotrexate and phenytoin. Clinical picture: anemia such as mentioned in the scheme. Neurological manifestations: 3 Ps. Vitamin B12 is an important cofactor for the formation of myelin sheath, so it will lead to peripheral neuropathy, pyramidal tract lesion, posterior column lesion, leading to loss of deep sensations. GIT manifestations: 3 atrophy, atrophic glossitis, atrophic gastritis, and atrophy in the intestine. No neurological manifestations in isolated folic acid deficiency. Then we have investigations: CBC, pancytopenia, MCV, MCH, MCHC increased except for MCHC, which is normal, and isocytosis, unequal size, poikilocytosis, abnormal shape. Color index more than 1. Bone marrow examination: megaloplastic hyperplasia. Measurements of serum B12 and folic acid. Serum B12 is less than 100 pg per milliliter. Normally it's more than 200. Serum folate is less than 4 nanogram per milliliter. Normally it's from 6 to 20 nanogram per milliliter. Then we have chilling test. It's by giving the patient vitamin B12 100 microgram IV to saturate body stores. Then we give the patient radioactive B12 1 microgram orally. Then we collect the patient urine in 24 hours and measure radioactive B12. If vitamin B12 is absorbed, it will appear in urine. Low excretion, malabsorption. Normal after intrinsic factor given orally, then this means pernicious anemia. Normal after antibiotics, bacterial overgrowth. Normal after pancreatic enzymes, pancreatic insufficiency. Therapeutic test, giving small doses of vitamin B12 or folic acid leads to reticulocytosis. Serological test, antiparietal cell antibodies, anti-intrinsic factor antibodies may be present in pernicious anemia. Then we have FIGLU test or FIGLU test for monoenoglutamic acid. Oral loading with histidine is associated with high urinary excretion of the FIGLU acid, which is an intermediate metabolite in the conversion of L-histidine to L-glutamic acid. Differential diagnosis. Other causes of macrocytic anemia such as myxedema, alcohol, chronic liver diseases, and myelodysplasia. Treatment, replacement therapy, vitamin B12 and for folic acid. Vitamin B12 hydroxycobalamin, intramuscular injection of 1000 microgram of vitamin B12 given daily for the first week, then weekly for the first month, then monthly for life. Lifelong disorder, and if the patient discontinues the monthly therapy, the vitamin deficiency will recur. Folic acid deficiency, 5 mg per day orally. Vitamin B12 is essential for the transformation of folic acid into the active form folinic acid, so large doses of folic acid may aggravate the manifestations of vitamin B12 deficiency, especially the neurological manifestations. Then we have hemolytic anemias. Definition: anemias due to reduction of lifespan of RBCs, increased rate of RBCs destruction. The normal lifespan is 120 days. Etiology: we have corpuscular and extracorpuscular. Corpuscular, membrane defect, hemoglobin defect, and enzyme defect. Membrane defect such as spherocytosis, PNH, and elliptocytosis. Hemoglobin defect, sickle cell anemia, thalassemia. Enzyme defect, G6PD, pyruvate kinase deficiency. Extracorpuscular, immune, infection, toxic, trauma, hyperspinism. Trauma, artificial valve, March hemoglobinuria, microangiopathic hemolytic anemia such as vasculitis and DIC, toxic, amphotericin B, lead, copper, snake venom, sulfa, infection, malaria, immune, isoimmune or autoimmune. Isoimmune, antibodies causing destruction of RBCs after transfer to another person due to ABO or RH incompatibility. Autoimmune, autoantibodies destroying RBCs of the same person, warm and cold type. We're going to talk about it later. Pathophysiology. Anemia occurs if lifespan is less than 15 days, as the bone marrow has the ability to increase its activity up to 8 times to compensate for hemolytic state. Hemolytic jaundice leads to increased unconjugated bilirubin. Intravascular hemolysis leads to hemoglobinuria and tubular damage with dark urine. Extravascular hemolysis in the RES system, reticuloendothelial system, leads to hepatosplenomegaly. Clinical picture, clinical general manifestations of anemia plus manifestations of hemolytic anemia, jaundice, mild, lemon yellow, urine, normal, maybe dark due to hemoglobinuria, and stool is dark. Intravascular hemolysis, hemoglobinuria, tubular damage, dark urine. Extravascular hemolysis in the reticuloendothelial system, hepatosplenomegaly, hemolytic crisis, fever, rigors, deepening of the jaundice, bone ache due to hyperactivation of the bone marrow, kidney, loin pain, and abdominal pain. We have other types of crisis: megaloplastic crisis due to development of folic acid deficiency, aplastic crisis, viral infection, inhibition of bone marrow, aggravation of anemia without deepening of jaundice, vaso-occlusive crisis in sickle cell anemia, occlusion of small blood vessels. Investigations: CBC, normocytic normochromic with reticulocytosis. So we have reduced RBCs and hemoglobin, normal YBCs and platelets, normal MCV, MCH, MCHC with increased reticulocytic count except in aplastic crisis. Reticulocytic count is a single test to detect hemolytic anemia. Color index 1, bone marrow examination, normoblasts, hypercellular to compensate for RBC's destruction, megaloplastic in secondary folic acid deficiency. Investigations for hemolytic jaundice. In serum, increased unconjugated bilirubin, but it never exceeds 5 mg percentage as long as the liver is normal. In stool, increased stercobilinogen, so we have dark stool. In urine, unconjugated bilirubin is water insoluble, so it's not found in urine, and the urine would be normal colored, but it can be dark due to hemoglobinuria. And we have increased urobilinogen. Decreased RBC's life, measured by isotopic methods. Investigations for intravascular hemolysis, hemoglobinuria. Diminished hemopexin and heptaglobin in plasma, normal plasma proteins which bind and clear hemoglobin released into the plasma. Investigations for certain types of hemolytic anemias. Coombs test to detect antibodies against RBCs positive in immune hemolytic anemia, whether direct or indirect. Direct to detect antibodies on surface of RBCs, indirect to detect antibodies in plasma. Treatment, fresh blood transfusion, splenectomy in some cases, and treatment of the cause is if possible. Then we have hereditary spherocytosis. Definition: it's disorder of RBC's membrane in which there is deficiency in spectrum protein, so the membrane becomes rigid and highly permeable to sodium and water. Rigid, so RBCs are trapped in small capillaries and spleen and they are rapidly destroyed. Normally the RBCs biconcave disc with diameter of 7 millicentimeters, red blood cells must be deformable to pass through the capillaries of 3 millicentimeters in diameter. Highly permeable to sodium and water will lead to taking the shape of sphere and early destruction will occur. Clinical picture: features of hemolytic anemia, positive family history, and onset is usually during childhood. Investigations: osmotic fragility test increased, hemolysis occurs at dilution of 0.7%. Normally it occurs at less than 0.4%. Blood film spherocytes, increased MCHC. Hereditary spherocytosis is the only important disorder associated with microcytosis and increased MCHC. Treatment: blood transfusion, folic acid 1 mg per day. Splenectomy best avoided in patients less than 10 years due to the risk of fatal infections post-splenectomy. Paroxysmal nocturnal hemoglobinuria. Blood cells membrane are more sensitive to complement system. Clinical picture: chronic hemolytic anemia, particularly overnight, because of hypoventilation, increasing carbon dioxide leading to acidosis and activation of complement 3, pancytopenia due to associated bone marrow hypoplasia, thrombosis, acute abdominal pain, myocardial infarction, and stroke. Complications: it may transform to acute leukemia in 5% of the cases, serious thrombosis in 20% of the cases, and it may progress to severe aplastic anemia. Investigations: HAM test, positive rapid hemolysis occurring if serum is acidified. Flow cytometric assays may confirm the diagnosis by absence of CD59. Treatment: general supportive measures plus steroids, bone marrow transplant, oral anticoagulants for thrombosis. G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency. This enzyme is essential for production of reduced glutathione, which protects RBCs from oxidizing agents. So in absence of glutathione, hemoglobin may be oxidized. X-linked disease, mainly affecting the males. Clinical picture: when patient is subjected to oxidizing stress, acute intravascular hemolysis occurs. Oxidizing agents are drugs: antimalarial, primekine, chloroquine; antibiotics: sulfonamides, ciprofloxacin, or another name for sulfonamide is cotrimoxazole; aspirin; diet: favabine, favin; infections. Types: type A, negrotype, I'm not racist, enzyme defect in old RBCs only, so the hemolysis is not severe. Type B, Mediterranean type, enzyme defect in all RBCs, old and recent, so the manifestations are severe. Favism in Mediterranean populations, hours or days after ingestion or even smelling favabines. Favabines contain oxidants such as vicine and convicine, and it may be fatal. Investigations for hemolysis, as previously mentioned. Assay of activity of G6PD enzyme. Blood film, we have Heinz bodies. Treatment: avoid oxidizing agents and blood transfusion in severe attacks. Autoimmune hemolytic anemia, acquired anemia caused by autoantibodies. We have two types: warm type and cold type. Warm type extravascular RBC destruction by reticuloendothelial system mediated by warm reacting antibody. Cold type cold heme agglutinin disease caused by RBC's antibodies that react most strongly at temperature less than 37 degrees Celsius. Etiology of the warm type: most cases are idiopathic 75%, secondary lymphoma, leukemia, SLE, and alpha-methyl dopa. Etiology of the cold type: idiopathic, infectious mononucleosis, paroxysmal cold hemoglobinuria, and mycoplasma pneumonia. Clinical picture of warm type, DIC, and features of hemolytic anemia, while the clinical picture of the cold type: Raynaud's phenomenon plus hemolytic anemia on exposure to cold. Investigations in warm type: the same for hemolysis plus positive Coombs test detecting antibodies on RBCs, IgG type. Blood films: we have spherocytes because when IgG attacks RBCs they become spherocytes. Immune thrombocytopenia may be associated, which is called Evans syndrome. While investigations in the cold type, they include general investigations for hemolysis plus positive Coombs test with IgM type antibodies. Treatment for the warm type includes prednisone 1 mg per kilo per day orally, immunosuppressive drugs such as azathioprine, and splenectomy, while for the cold type, avoid exposure to cold, cyclophosphamide, and azathioprine. Hemoglobinopathies: hemoglobin is composed of heme and globin, heme iron porphyrin complex, globin protein consisting of 4 polypeptide chains. We have hemoglobin F, alpha 2 gamma 2, hemoglobin A, alpha 2 beta 2, hemoglobin A2, alpha 2 delta 2, hemoglobin F, okay, I have previously mentioned it. Sickle cell anemia. Definition: hereditary disorder in which there is production of abnormal hemoglobin S, valine replacing glutamic acid at position 6 in the beta globin chain. It's of two types, homozygous and heterozygous. Homozygous sickle cell anemia, hemoglobin SS, leading to manifested anemia. Sickling may occur with mild hypoxia, while the heterozygous sickle cell trait, hemoglobin AS, asymptomatic. Sickling may occur with severe hypoxia. Clinical picture: general manifestations of hemolytic anemia without splenomegaly, vaso-occlusive crisis, abnormal sickling of RBCs leading to vaso-occlusion, leading to tissue infarction resulting in pain and or tissue damage, brain, strokes, eye, retinal detachment, heart, myocardial infarction, kidney infarction, hematuria and chronic renal failure, spleen infarction, autosplenectomy, so we have no splenomegaly, abdomen, mesenteric blood vessels occlusion leading to acute abdomen, bone, pain, penis, priapism, leg ulcers, infections, pneumococci and salmonella. Investigations for diagnosis of hemolytic anemia: hemoglobin electrophoresis, hemoglobin S is high, which is diagnostic, blood film, sickle cells, especially after inducing hypoxia by adding sodium methylbisulfite. Treatment: blood transfusion, symptomatic treatment, analgesia or oxygen therapy, IV fluids, exchange blood transfusion if stroke or visceral damage, to reduce hemoglobin S to less than 30%, pneumococcal vaccination. New lines of treatment: gene therapy, stem cell transplantation, and hydroxyurea because it elevates hemoglobin F and this would reduce hemoglobin S. Thalassemia. Definition: hereditary disorders characterized by reduction in the synthesis of globin chains alpha or beta. Reduced globin chain synthesis leads to reduced hemoglobin synthesis and producing hypochromic microcytic anemia because of the defective hemoglobinization of RBCs. We have alpha and beta. Alpha, decreased production of alpha chains. We have 4 alpha genes, so the disease is caused by gene deletion divided into 4 types. 1 gene deletion, silent carrier, asymptomatic. 2 gene deletion, alpha thalassemia minor or trait, mild hypochromic microcytic anemia, diagnosed by exclusion, no splenomegaly, and requires no therapy. 3 gene, hemoglobin H disease or beta 4, hemoglobin H or beta 4 from 30 to 40%, hypochromic microcytic anemia, splenomegaly, and treatment includes blood transfusion, folic acid, splenectomy in some cases. 4 gene, alpha thalassemia major, hemoglobin H and hemoglobin BART, gamma 4, exceeds 80%, and this leads to death in utero, called hydrops fetalis. Beta thalassemia, decreased production of beta chains which are replaced by gamma or delta chains, leading to production of hemoglobin F and hemoglobin A2. There are 3 types: thalassemia major, thalassemia minor, thalassemia intermediate. Thalassemia minor or trait, hemoglobin A is slightly reduced with increasing in hemoglobin F and hemoglobin A2 by 5 to 10%. It represents in adults by mild anemia and splenomegaly requiring no treatment. Thalassemia intermediate, variable hemoglobin A, not requiring regular blood transfusion, but it's more severe than the thalassemia trait and milder than the thalassemia major. Thalassemia major or Colles anemia, hemoglobin A markedly reduced and hemoglobin F markedly increased 90%. Clinical manifestations starting at the age of 6 months when hemoglobin synthesis switched from hemoglobin F to hemoglobin A. Severe anemia requiring lifelong blood transfusion, hepatosplenomegaly, hypersplenism, growth retardation due to chronic anemia, bony deformities, flat bones, pathological fractures, facial appearance, protrusion of the frontal and parietal bones, prominence of malar eminences and prognosis, depressed nasal bridge, hemochromatosis due to transfusional iron overload, developing due to the body's inability to excrete iron from the transfused red cells. The causes of death in thalassemia, beta thalassemia, are congestive heart failure, recurrent chest infections, and multiple organ failure. Investigations: peripheral blood examination, reduced RBCs and hemoglobin, microcytic hypochromic anemia, target cells, aniso and poikilocytosis, hemoglobin electrophoresis. It's diagnostic. With major, we have hemoglobin F, and with minor, we have increased hemoglobin A2, X-ray, skull, hair on end appearance, long bones, thin cortex, wide medulla, serum iron and ferritin are increased. Treatment: we have blood transfusion, a lifelong blood transfusion for the major. Intermediate doesn't require regular blood transfusion, and minor doesn't require any treatment at all. The aim of blood transfusion to keep hemoglobin concentration. If more than 6 grams per deciliter, simple. If more than 10, hypertransfusion. If more than 12, then it's super transfusion. Avoid diet rich in iron, iron chelating agents, desferoxamine, intramuscular or subcutaneous, and deferricerox. Orally, folic acid 1 mg per day orally, antibiotics for recurrent infections, splenectomy indicated especially in cases of hypersplenism. New lines of treatment: hydroxyurea, stem cell transplantation, and gene therapy. Anemia of chronic disease definition: low condition. It's a condition of impaired iron utilization where functional iron or hemoglobin is low, but tissue iron such as in storage is normal or high. It's seen in chronic illness such as chronic infection, chronic inflammation, liver cell diseases, renal failure or malignancy. Pathogenesis: failure of iron utilization, decreased lifespan of RBCs, impaired release of iron from macrophages, impaired erythroid precursors to respond to erythropoietin, and decreased erythropoietin is a rarely important factor except in renal failure. Clinical picture of the cause and clinical picture of anemia. Investigations: anemia is initially normocytic normochromic, then it becomes microcytic hypochromic as the disease progresses. Iron profile: decreased serum iron, decreased TIBC, decreased transferrin saturation, while the serum ferritin is normal or high. For the cause, we have kifts and lifts with tumor markers. Treatment: iron supplementation not required except in iron deficiency anemia. Treatment of the cause: in most cases no treatment is necessary because it's usually mild anemia. And finally, we have erythropoietin. We have comparison between iron deficiency anemia and anemia of chronic disease. You need to know that serum ferritin is reduced in iron deficiency while it's normal or raised in anemia of chronic diseases, while TIBC is raised in iron deficiency while it's reduced in anemia of chronic disease, and iron in bone marrow is absent in iron deficiency while it's present in anemia of chronic disease. Then we have anemia of chronic renal insufficiency. Etiology: this condition occurs due to decreased erythropoietin production and may occur as the creatinine clearance declines below the level of 50 milliliter per minute. Diagnosis: CBC, normocytic anemia. Clinical picture and investigations of chronic renal failure. Treatment: erythropoietin. Adverse reactions: hypertension and seizures. And for association of iron deficiency anemia, we may have suboptimal responses, so we give patients IV iron supplementation. Anemia in endocrine diseases: pituitary panhypopituitarism associated with normocytic normochromic anemia and leukopenia. In hypothyroidism, we have menorrhagia, which leads to associated iron deficiency anemia, and we should check vitamin B12 levels. Adrenals. Cushing leads to erythrocytosis and increase in hemoglobin by 1 to 2 gram per deciliter. The mechanism is unclear. While in hypoadrenalism we have normocytic normochromic anemia, but the plasma volume is decreased, and this leads to masking to the true degree of associated anemia. The abnormalities are corrected by replacement of mineral corticoids. Parathyroid. Hyperparathyroidism associated with anemia due to impairment of erythropoietin production, and in some cases from secondary marrowsclerosis. Diabetes mellitus, it's usually due to the secondary disease-related complications of the diabetes, such as renal failure, and it may occur due to poorly controlled diabetes mellitus. And this concludes our chapter for today.